be talking about EKG and electric activity of the heart. So, first of all, there's the electric activity of the heart, and this includes like depolarization, contraction coupling mechanism of the heart, and pacemaker activity, as well as like key features of the sinoatrial node cells. And the SA node cells have these funny channels that allow for sodium leakage that allows it to contract very fast and for prolonged times. And this causes the depolarization and contraction coupling of the heart. So there are different nodes of the heart. First of all, it's the sinoatrial nodes, atrioventricular nodes, and his Purkinje systems. The respective locations, functions, and special features of these pathways are given in the table. And there's also a conduction sequence of these nodes. First, it's the SA node that fires. Depolarization then spreads throughout the atria. Then the AV node pause allows atrial contraction to complete ventricular filling. A wave travels through the Purkinje system, and lastly, depolarization moves down the septum, apex, and base. And ventricular depolarization pattern is also there. This is very important because if everything depolarizes and polarizes at the same time, the heart cannot pump blood. These are general EKG principles. These principles are when depolarization approaches an electrode, then the positive deflection occurs. When depolarization moves away from an electrode, negative deflection occurs. This is the basic principle. And the action potential characteristics are given below in the table below. So there are two types of lead placements for ECG systems. First is the standard 12 lead ECG system. These 4 electrodes are placed on the limbs, respectively on like all of the limbs, and there are also precordial leads that are placed on the chest landmarks. There are ECG lead groups depending on where they're placed, and these are the first, second, and third lead groups. And they're divided into like a respective location, how they're placed. And the precordial leads, they're V1 to V6. These are unipolar leads that are placed across the chest wall, and there are different heart views for the different lead groups and where they're placed. For example, leads 2, 3, and AVF are placed on this inferior lead group views these leads, and then the clinical use for these is to detect myocardial infarction of the inferior wall of the heart. These are the clinical significances and applications of why we view the heart this way. So, reading EKGs, there's a systemic approach to ECG reading. So we analyze the rhythm and calculate the rate, axis determine the axis, like with the different leads and where the signals go. There's also chamber assessment. The PQRS waves are important in assessing the chambers. There are normal EKG values, so for all the like P, PR, and QRS intervals. Then there's the QT interval, QRS axis. These are all like the normal normal values for EKG. And there are common abnormalities here. And yeah, there's atrial enlargement, tall peaked P waves. Left atrial is biphasic P waves. There's also ventricular hypertrophy, conduction blocks. Conduction blocks are really dangerous because it means arrhythmia in the heart. So you can completely and die fast from conduction blocks. And there is the findings you can find and how to interpret them. The category goes rhythm, conduction, morphology, and red flags. Red flags are really important, but so is everything else, but it's the most important one. Then what are red flags? So like finding new Q waves that shouldn't be there, the QT interval prolongation, complete heart blocks, ventricular arrhythmias, like the T wave representing something it shouldn't represent, and then like complete reset prepares the heart for the next cycle which shouldn't, and both the right and left ventricles finishing contraction simultaneously. So that shouldn't be the case. So these are red flag findings. And then there's also the 5-lead placement, which is for continuous monitoring, and we also talked about the 12-lead placement before. This is the placement of the 12-lead placement. There are also common errors that happen, and the consequences for these can be pretty big if you for the results. And there's also pediatric considerations which change the results, and also you have to take good documentation of your testing. Now we're into respiratory mechanics. So breathing mechanics is composed of inspiration and expiration that involves the muscles contracting and relaxing. And there is the respiratory cycle, which involves all of these volumes and reserves. So these are the normal lung volumes and capacities, and what they mean. For example, like tidal volume being basic breathing unit. These are the muscles involved in breathing. They are primary and accessory muscles. So the diaphragm is considered the most important muscle of inspiration. There's also external intercostals that help in rib elevation, scalenes, I guess, that help in accessory muscles. And there are accessory muscles, which are like abdominal muscles and other accessory muscles that help in breathing. So in spirometry, there is the procedure overview basically what spirometry is. It is basically the maximum inspiration followed by maximum expiration and forced expiratory volume. All these volumes are basically what you expect to get out of using spirometry to diagnose an individual. And these are the test performance. So how to prepare the patient, how to position the patient, and what technique to use. How much effort is needed for inspiration and expiration. There's also the duration of breathing. And these are the patterns recognized. There's the obstructive pattern, which basically obstructs the normal flow of air of the lungs. FEV1, FEC, FEV1 and FEC are like reduced below 80%. FEC is normal or reduced, and both of them can be ratio between them can be decreased, and it can be below 0.7. And if this occurs, it can be asthma, chronic obstructive pulmonary disease, and also chronic bronchitis. So chronic long-term diseases can cause this. There's also the restrictive patterns, which the FVC is reduced, the FEV1 is reduced proportionally. FEV1 FVC ratio is normal or increased higher than 0.7. This can be because of pulmonary fibrosis, chest wall disease, or even like lung collapse. There's also the mixed pattern, mixed of these two patterns. FVC is reduced, FEV1 is reduced, and the ratio between the two can be anything really, variable. And examples of this include combined obstructive or restrictive disease, so a combination of the two diseases. So there are quality criteria of minimum of 3 acceptable maneuvers. There's reproducibility, effort, and exhalation. So you have to have these qualities for the test to be valid. And the most important part is interpretation of the values. So there's quality check, 3 acceptable maneuvers. If it's above that, then that means, the patient is normal. If the patient is giving poor effort, coughing, or like glottis closure, that's abnormal. FVC is above 80% predicted, and if it's abnormal, it's below 80%. The ratio between the two is supposed to be above 70%, but in abnormal conditions it can be below 70%. Severity is based on stages of the ratio, and if it's below 80%, it's considered mild, and if it's below 50%, it's severe. So what you have to do is check acceptability and reproducibility compared to reference values, identify patterns, and grade the severity based on the percentages, and consider extra bronchodilator responses. So these are the grading scheme, basically. Normal if it's above 80% predicted, mild if it's 70 to 79%, moderate if it's 60 to 69%, and moderately severe if it's 50 to 59, severe if 35 to 49, very severe if below 35%. Yeah, so thank you.